Ma'am, over to you.
Thank you, Sri Priya, and thank you everyone once again for joining us for today's session. As Sri Priya was mentioning, today we'll be talking about palliative care aspects or the context of palliative care in non-cancer illness. So today we have as our faculty Dr. Sunitha Daniel. Dr. Sunitha is a specialist medical officer working under National Health Mission in Ernakulam, Cochin, that is in Kerala. But she has almost more than 10 years of experience in UK, and she has been with NHS for many years. And she has her MRCP in general medicine and palliative medicine. She has, I think, a lot of publications. If you Google her name in Scholar, a lot of very interesting studies she has done. I think the very recent one which I read was about qualitative study women with breast cancer, which is very interesting read. So those who are interested, please go through those articles. Welcome, Dr. Sunitha, for today's session, and thank you so much. I know you have been busy with your work, but thank you so much for agreeing to the session.
Thank you, Sridevi. Thank you once again, Palliative Media, for the opportunity. Let's start by sharing my screen. Okay, my screen is visible, right?
Yes, yes.
So I think, as Sridevi mentioned, the topic for today is palliative care in non-cancer illness or not malignant illness. In this session, what we're trying to cover or trying to understand is why the patients with non-malignant disease would benefit from palliative care, and which all groups are those that specifically we can make a difference, and how do you identify such patients. And I know that non-cancer or not malignant is a vast topic, so it's difficult to cover the whole session within an hour's time. So I'll be basically touching on the important conditions, and that too the important points of those important conditions, which might help you in your clinical decision making. So mainly the COPD, heart failure, dementia, some bits about other neurological conditions, end-stage kidney disease, and end-stage liver disease. You must all be familiar with this definition of palliative care or palliative medicine from WHO, which was in 2002, and where we defined palliative care as that focus on patients with life-threatening illness and how we aim to relieve the suffering. But in 2018, the palliative care has been redefined. So International Association for Hospice and Palliative Care have redefined palliative care in 2018, which has since been accepted by the consensus. And the specialty will now cater to patients and caregivers with serious health-related suffering. So they've introduced a new concept of serious health-related suffering. And there are a number of conditions that come in this list. So they've also provided, if you go to the Lancet article, it also gives us a list of about 20 conditions that will fall in that category, which has got cancer, but lots of non-cancer conditions also. So the scope of palliative care has been expanded now, and we need to provide our services to a lot of non-cancer patients now. Now, they have also given us a graph of how badly this serious health-related suffering is going to change from, if you compare from 2016, and they have sort of projected how it's going to change in 2060. So if you look at this map, it shows the predicted increase in SHS by the World Bank income region. So you can see, as you can see from the figure, the dark green color, which shows both low income and low and middle income countries, actually has a predicted increase about 155% for low income and 87% for low and middle income countries. So that much is the burden of serious health-related suffering that we are going to face in our country. This is another chart which shows the predicted number of deaths due to various conditions and how that is also expected to shift. So you can see that the malignant conditions which tops the list, but in addition, it's expected that the number of deaths due to CVA, lung disease, and dementia will also rise by 2060. So it's not just cancer that we are going to be worried about in the future. And similarly in India also, the situation is not different. So you can see this is a deaths in India caused by both communicable and non-communicable diseases. So the portion shown in red is actually deaths because of communicable disease, communicable maternal, neonatal, and nutritional diseases. And you can see that the graph, the area in the red is actually coming down, but unfortunately, the non-communicable disease or the blue bit is coming up. So, the people are dying more with non-communicable disease, and we predicted to do that in the future as compared to communicable diseases. So India has always been battling communicable disease, and but now what we're seeing is that there's a trend of shifting towards the NCDs, and which include not just cancer, we've got cardiovascular disease, chronic respiratory diseases, and diabetes. And the problem with NCDs is that they start quite early in life, and because of the development of treatments, people tend to live longer, and so it'll be a lot of burden to manage these patients as they grow older, because they'll require a care of long period of time. And again, it's all because of the unhealthy lifestyles, unhealthy eating, excess alcohol, and physical inactivity. That also, so basically we need to do primary prevention, secondary prevention, and tertiary care for these patients. And there's a huge burden of these NCDs that's going to come, that our country is going to face in the future. This data is from 2017, where it's the ICMR has given us that there's a state level disease burden shows that 48 to 75% is the current burden of NCDs. And ICMR also goes on to state that Kerala, Goa, Tamil Nadu provides the highest number of this burden. And the lowest number actually comes from Bihar, Jharkhand, Uttar Pradesh, and Rajasthan. So there is definitely a growing trend towards the high burden of NCDs. Okay, before I proceed, I'll just like to ask a short MCQ. So we'll give you about 30 seconds to answer this in chat box. And you can guess your answer. So the question is, what is the most common symptom cluster of advanced cancer, as well as AIDS, heart disease, COPD, and renal disease? So as you know, from palliative care, we always deal with symptom clusters, not just a single symptom. So what do you think is common in all these conditions, along with advanced cancer, AIDS, heart disease, COPD, and renal disease? So is it pain, breathlessness, and fatigue together? Is it pain, vomiting, and constipation, breathlessness, delirium, constipation, or depression, anxiety, and anorexia?
There are responses, mixed responses, A, D. A is the most common response.
Okay, very good. So it's that's the answer. That's the answer I was expecting. So pain, breathlessness, and fatigue are the most common symptom cluster. And the reason I mentioned that was because now we know that it's common in cancer. So this was a paper published in 2006 by Solana et al. In JPSM, which shows that pain, breathlessness, and fatigue are very common in advanced cancer, but also in the non-cancer conditions like AIDS, heart disease, COPD, and renal disease. So that's the most important thing to need to remember, because everybody knows, or at least most people know, that if it's cancer patients, you need palliative care, isn't it? And cancer patients tend to get palliative care. But what about the non-cancer patients? So these are the symptom profile of these conditions. And you can see that even though cancer, all the symptoms which are in cancer are commonly or sometimes more in non-cancer conditions. So for example, breathlessness, 90 to 95% of COPD patients will have breathlessness, but only 10 to 70 in cancer have breathlessness. Similarly, if you think of HIV, pain, you can see 60 to 80% in HIV have pain. Depression, again, HIV is common in depression. Anorexia, COPD is present. Fatigue, heart failure is present. So all these symptoms, all these non-cancer conditions do have a high symptom burden. But unfortunately, because due to lack of services or because they're not being referred, they don't get the services that the cancer patients get. So how do you decide, or how do you decide among these non-cancer patients, whom or at which stage can you refer them to palliative care? So this is a very good tool which can be used to identify the patients with advanced life-limiting conditions and who can benefit from palliative care. It's called the Supportive and Palliative Care Indicator Tool, or SPIC tool. Now, I'll be talking about this tool towards the end of the presentation also, where this tool is actually quite useful. If you go to the tool, it can see, it tell you what are indicators to look for in different advanced conditions, including cancer, dementia, frailty. So at what stage do you refer them to, or do you have to think about referring them to palliative care? Kidney disease, liver disease, and respiratory diseases. So it's a very useful tool for you to refer and read upon. And what it says is that 2 or more general indicators of deteriorating health and any clinical indicator of 1 or more of the advanced conditions means that the patient has to be referred to a palliative care team. Now we'll individually go through some of the conditions and to remind us what we need to remember about these conditions. So first we'll start with COPD. Now, there was a study published as early as 2000 in Thorax. It compared the quality of life in end-stage COPD and lung cancer. And what they found was that the patients with COPD had poor quality of life, as well as more breathlessness when we compared to those with lung cancer. But what we found was that none of the patients with COPD actually received any specialist palliative care services. So this is basically comparing the quality of life and symptoms. So the quality of life and symptom was poor in non-cancer COPD condition as compared to cancer, but unfortunately, none of them received any palliative care input. Similarly, another prospective study, cohort study of seriously ill patients, hospitalized patients with COPD and lung cancer. So basically, they were asked the questions about whether they would want supportive care towards end of life and whether they would want ventilation or not. And equal number of patients from both the groups, so from the cancer group and the COPD group, the patients were asked whether they wanted towards end of life. What was the preferences? The advanced care planning was asked, and they were asked whether they would want ventilation towards end of life. But what we found was that none of the equal number of patients from both groups only wanted supportive care and didn't want the invasive ventilation towards end of life. But when they followed the patients later on, they found was that most COPD patients actually received ventilation, 70% as compared to 20% of the other group. So again, people at that point were not being asked what they want. This is in early in 2000. So the patients were not even given opportunity to say what they wanted. So how can we help patients with COPD, and what stage we have to manage them? Now, this is a step-by-step approach in managing patients with advanced COPD, especially the symptom management. So if you think of dyspnea, it's the most troublesome symptom in patients with advanced COPD. So they've given us a guideline. There's a guideline to manage these patients step by step. So as we all know, initially when the patient has got COPD, they are usually been put on the pharmacological therapies. So they are including short-acting bronchodilators, long-acting anticholinergics, inhaled corticosteroids, and long-acting beta-2 agonist. Neuromuscular, all these pharmacotherapies are put at the first stage. We all know that the respiratory physicians actually do that. Theophylline, then when they go into hypoxia, they put on oxygen for hypoxia patient. Now, what happens is as the disease progresses, they tend to become more and more breathless. So in spite of all this maximal medical treatment, you can see that the patients are still breathless. So they have now actually recognized a new syndrome called chronic breathlessness syndrome. So these are the group of patients who are on maximal medical therapy for whatever disease, but they are still breathless. So we have to move on to the second stage where you teach some non-pharmacological management of breathlessness. And I'm hoping it would have been covered for you in your breathlessness presentation or talk. So basically things like respiratory physiotherapy exercises, breathing exercises to train your breathing, pursed lip breathing, walking aids, chest wall vibration, and neuromuscular electrical stimulation. And then even after that, the patient is still breathless, then they move on to the next step, which is initiating and optimizing the opioid therapies, including short-acting and long-acting morphine and other opioid agents. So this is how you manage patients with advanced COPD. And the advantage of this is that, so when patients are referred earlier on at this stage, we can actually manage some side by side along with the pulmonologist. And then we establish a rapport with the patient. And so we can get involved in not just symptom management, but also advanced care planning, as well as towards end of life care also. So that will help us to manage the symptoms, as well as help us to avoid unnecessary hospital admissions and manage them at home if possible. So we come to a next question. So I've got a patient here. He's Mr. Kumar. He's 70-year-old. He has advanced chronic obstructive pulmonary disease. He attends a clinic to see you due to his worsening breathlessness. Despite maximal medical therapy, he has had 3 admissions to hospital in the last 12 months with exacerbations of COPD. He was assessed for home oxygen therapy while in hospital, but did not meet the criteria. Your clinical assessment excludes any reversible cause like infection. So if you've got Mr. Kumar with you, he's very, very breathless, and he probably has something called as a chronic breathlessness syndrome, because he's on maximal medical therapy and he's still breathless, and he's had 3 admissions to hospitals in the last 12 months. So which one of the following would be the most appropriate next step in managing Mr. Kumar? Will you actually prescribe benzodiazepine at low dose to be taken when he feels especially breathless? Will you prescribe a short course of steroids and antibiotics and ask him to come back if he does not feel better? Will you refer him for cognitive behavioral therapy, as anxiety is likely to be a contributory factor? Will you discuss the use of handheld fan and explore whether the patient would be willing to be referred for advice regarding breathing exercises and involvement of palliative care team? Or will you prescribe morphine 20 milligram orally as required? So you can put that as A, B, C, D, and E. So there are 5 choices. I'll give you a few seconds for that.
There is like D and C, B, D.
Okay.
D is the most.
D. Okay, fine. So yeah, I think all these answers probably can be correct, but if you follow the protocol or the step that I was talking about, maybe at this stage is a time when you should be discussing handheld fan and explore whether he can be referred for advice regarding breathing exercises and involvement with the palliative care team. Now, after that, probably if his anxiety is worsening, he might benefit from benzodiazepine later on. Right now, again, he doesn't have any exacerbation, so maybe there's no point in giving some steroids or antibiotics at this point. CBT again can be useful later on. Morphine can be started, but this dose is quite a higher dose. So usually we start at a lower dose for such patients for breathlessness. So the answer here would be to starting on the non-pharmacological methods to manage breathlessness. So this is how, for COPD patients, our role as a palliative care physician can be: one is for symptom management, so breathlessness, including both non-pharmacological and pharmacological management, referring to physiotherapy services, including the physiotherapists in your team to manage him. Then advanced care planning, deciding, avoiding hospital admissions if possible, because all these exacerbations and admissions that probably are not typical exacerbations, because it could be because of the breathlessness and panic attack that happens because of the chronic breathlessness syndrome. So if we are able to manage the breathlessness, we might be able to avoid hospital admissions and manage him at home. So that's about a snapshot of COPD. Then we come to heart failure. So heart failure is also, it's a very common problem in our country right now. Incidence in UK in heart failure is 1 in 1,000 population. I was not able to get much of a data on incidence in India. I got a data about prevalence in India, which is actually a very range of numbers. So 1.3 to 23 million was one of the studies saying about the prevalence in our country. And we know that as NCDs go, a number of NCDs in hypertension and diabetes and all these conditions, stroke, all the comorbidities increases, that chance of getting heart failure is also very high. And obviously, as you become older, the chance of having as people tend to live longer, the chance of getting heart failure is also high. The problem with heart failure is that they do have a poor survival rate as compared to breast and prostate cancer. But people don't realize that, isn't it? Because if you get a cancer diagnosis and you think that's the end of everything. But actually, early cancer, breast or prostate cancer is detected quite early. People tend to survive more than a person who's been diagnosed with the heart failure. And what they say is that the study shows that half the patients diagnosed with heart failure die within 5 years of first hospital admission. So suppose your heart failure is bad enough for you to end up in a hospital, then the likelihood that 50% of such patients actually die within 5 years. So your prognosis is actually less than 5 years after the first hospital admission. And that is probably quite shocking as compared to the cancer diagnosis. And again, 1/3 to 1/2 of patients die suddenly irrespective of heart failure stage. So things like arrhythmias and sudden death can occur in heart failure patients. Again, that's very important to realize because it's important to communicate that to the patient and the family. So you have to discuss the potential for sudden death with the family because the preference of care must be discussed. So it's important for heart failure patients also for palliative care, principles of palliative care to be applied, especially for symptom management and for advanced care planning. Now, I'm just going to give you a brief idea about the classification or the stages of heart failure based on the New York Heart Association heart failure class, as well as the American College of American Heart Association, so ACC and AHA classification. So in NYHA class, it's divided into none, class 1, class 2, class 3, class 4. And the AHA classification is divided into stage A, stage B, stage C, and stage D. So basically, if class 1 of NYHA is actually equivalent to stage B of AHA classification, and it means that heart disease is present, but there are no symptoms. And according to definition, there is no limitation of physical activity. Now, class 4 means unable to carry out any physical activity without discomfort, and which is equivalent to a stage D of AHA, which means that there's advanced heart disease and there's continued heart failure, and the symptoms require aggressive medical therapy. Now, the reason I'm giving you this classifications for you to understand how do we decide on which medications to start. So this classification tells us which medication to start at which stage, and again, it also tells us what medications are important for us in which stage. So for example, when you have a class 1, NYHA class 1, then you need to put them on ACE inhibitors and beta blockers. And these ACE inhibitors and beta blockers will actually decrease the hospital admission, increase the survival, and also improve the functional status. So most of the medications that the patients with heart failure are taking are important to improve the functional status. So that is why it's important for us to, when we think of rationalizing medications, especially when the patients reach palliative care, we normally tend to stop all the medications. But for heart failure, it's important for us to remember that some of this medication will have to be continued to improve the quality of life. So at that point, obviously, we actually check the risk and benefit. Like for example, by continuing some medication, suppose the patient's blood pressure falls drastically down and they become very dizzy and they're not able to do their activities, then obviously we'll have to stop. Otherwise, we'll have to continue all these medications if possible, if the patients can tolerate without any side effects. So medicines like diuretics, ACE inhibitors, beta blockers, mineralocorticoid antagonists, and digoxin, these are the medications that's normally started for heart failure. And this table gives you at which point it's been started. Right, so coming to my next question, what percentage of patients diagnosed with heart failure die within 5 years of the first hospital admission? Is it 30%, 40%, 50%, or 60%?
C is the response.
Okay, so that's good. So it's 50% of patients actually die within first 5 years of hospital admission. So we come to the next topic, which is end-stage kidney disease. Now, end-stage kidney disease, again, it's important for us to know about end-stage kidney disease because we all know that when they reach end-stage, they do have an extremely poor quality of life. And they also have frequent hospitalizations. And again, just like I mentioned in heart failure, the prognosis of end-stage kidney disease also is comparable to that of common malignancies. And what all symptoms do these patients have? They can have dyspnea, confusion, pain, anxiety, depression. It's very common during the last few days of life. So again, it's important for palliative care team to get involved. But it's not just that. Now, this was a very interesting study, and this is a landmark study which is conducted in UK. And the first author is actually one of my colleagues in UK. She was a trainee along with me. And she actually did this study before she started palliative care training in UK. So what they did was, this was published in 2013. And this is a retrospective observational study which compared the survival and the palliative care involvement of two groups of patients over 70 years of age. So what happened is that they set up a combined clinic there, and patients were above age of 70 were given the option of when they have to do it, when they reach the stage when dialysis has to be started, these patients were given an option of not going for dialysis and just going for a conservative management. And some group of patients who went for dialysis continued with that, and some group of patients opted to go for a conservative management. And both the patients are advanced CKD, that means end-stage renal failure with an eGFR less than 10. So what they found was that and in the study, what they compared was that they compared the survival, the hospital admissions, and the palliative care access of the patients who were above age of 70 with a chronic kidney disease stage 5. And the two arms, one was dialysis and one was conservative management. So what they found, the surprising thing, the thing that was everybody expected was that the quality of life obviously was better for the patients who went for a conservative management rather than that went for renal replacement therapy, which was expected. But the thing that was surprised everybody was that patients above the age of 80 with the poor performance status or high comorbidity scores, they survived longer when they chose conservative treatment as compared to dialysis. And as expected, those who conservative also had more access to palliative care. So, but 70 to 80, the survival benefit was for the patients who went for renal replacement therapy, but patients who were above the age of 80 actually survived better if they didn't go for dialysis, but they went for conservative management alone. So this is a recent. So this was like a landmark study. Everybody, was surprised to see that even actually going for dialysis was actually not doing them any benefit, but actually causing more harm than good, especially for people above the age of 80. And we also know that conservative management party people had greater access to palliative care, and they were less likely to be admitted to hospital or to die in hospital. Now, actually, since then, the renal supportive care has been a developing specialty, developing branch. There's lots of people with special interest in that. And in India also, it's renal supportive care work has been going on since 2018. And it involves some didactics lectures through Project ECHO, which had about 8 weeks of session training the palliative care physicians in different parts of the country. The KMC Manipal also organized a masterclass in renal supportive care. And then subsequently, the Indian Journal of Palliative Care has brought out a supplement just for the renal supportive care for all the literature and articles that's been published in India on renal supportive care. So who all will benefit from in end-stage kidney disease? Patients who benefit from palliative care are those who choose or advise not to embark on dialysis, or those who chose conservative non-dialytic management. Second group can be those who are failing to thrive on dialysis, or those who experience worsening quality of life or increasing symptom burden despite dialysis. And the third one is those who discontinue dialysis. So these patients are thought to be benefiting from palliative care in end-stage kidney disease. So that comes to the next question. Which are the patients who benefit from palliative care in end-stage kidney disease? So as we all know, all these three groups of patients will benefit from palliative and end-stage kidney disease. And what we have found is that suppose the patient is established on dialysis, and then towards the end they decide that they don't need any further dialysis and you stop dialysis. The average survival of such patients is actually about only 8 days. So they need extensive palliative care. They're definitely going to die when you stop the dialysis abruptly, especially people who are dependent on dialysis. So they will have to be referred to a palliative care at least for the end of life. And so all these patients will actually improve with a palliative care, or we need the support of supportive care and palliative care towards the end stage. So what do you do? What can we do for such patients if a patient decide to go in a non-dialytic route? Now, this is more important in India, mainly because people might not be able to afford dialysis, because you know that when people go in a dialysis route, it means that they'll have to do it at least thrice weekly. They should have facility to do that. They should have the financial backing to do that if it's not been provided by the government's support, and they should have people to take them to the institutions. And there's a lot of burden involved in continuing a life with dialysis, and people might decide not to go in that route. So that is why it's more important. The supportive care for such patients is more and more important in our country. And what all should we do for such patients? The main thing to remember is maintaining the fluid balance. So we'll have to maintain a tight balance of how much they're taking, making sure they don't go into fluid overload, and make sure that diuretics are adjusted so that it doesn't worsen the kidney functions further. So again, a balance has to be maintained with that. Treatment of anemia is very important. They might need long-term erythropoietin injections because anemia can cause fatigue and worsening of symptoms. Then correction of acidosis and hyperkalemia, and along with blood pressure management. The dietary modification is very important for such patients. Calcium and phosphorus metabolism management, and individualized symptom management and supportive care are crucial to maximize the quality of life. So there'll be symptoms like pain and itching and fatigue, nausea, sometimes uremic complications. All these symptoms might be there. So we need to give the medications that is according to the renal function. So the medications has to be adjusted accordingly. And all these has to be taken care of in the supportive care clinics. Now we come to a next branch, which is dementia and other neurological conditions. Now, advancing dementia, the number of, again, symptom management is very, very important. So when you think of all these conditions, important thing to remember, as we all know, is that palliative care actually deals with management of symptoms. Is one of the priorities that we deal as palliative care physicians. So symptom management is very important. And what are the common symptoms seen in patients with advancing dementia? Confusion is the most common symptom. 83% of patients can have confusion. Then patients can have urinary incontinence, pain, low mood, depression, constipation, loss of appetite. Again, these are common symptoms that we come to see in most of palliative care patients, and this is what dementia also has. Now, there are a number of scales or tools that can be used to assess the worsening or the prognosis of dementia. The scales like clinical dementia rating scale, the functional assessment scale or FAST scale, and the global deterioration scale or the GDS scale. Now, we all know that we diagnose dementia depending on the MMSE or the mini Mendel state examination questions. And, depending on the answers to the questions, we classify them as mild cognitive impairment, moderate, and severe. So once the diagnosis of dementia is made, then depending on what all they can do, we scale them according to the FAST scale. So you can see that, this scaling, this is stage 1 to 7 in FAST scaling, where stage 1, if there's no subjective objective difficulty, they've got a diagnosis of dementia, but they don't have any subjective objective difficulty. So that's like a normal adult. Now, 2 has got complaints of misplacing objects and subjective word find difficulties. And this is something that they call as a normal older adult. So anybody who's old might have such problems. So it's a normal older adult. The 3rd is the difficulties of the performance, which is evident to the co-workers. And that is actually an early dementia. And what's been seen is that the average duration of this stage is actually 7 years. So once you have a diagnosis of dementia, and once they're in a stage of 3, but it's early dementia, the average duration of a patient who can be in that stage is for 7 years. Then they progress on to a mild dementia, that is stage 4, where there's impairment in instruments of activities of daily living. And the average duration of this stage is about 2 years. They progress on to a moderate dementia, which is stage 5, where what's described is that they need assistance with dressing to match the weather occasion. So basically things like, if you have to, if it's cold, you're supposed to wear, warm clothes. That sort of, they're not able to recognize that aspect. So that is called a stage 5. And then stage 6 and stage 7. 6 becomes moderately severe dementia, and that has got A to E category, where difficulty comes in dressing, bathing, toileting without assistance, then urinary incontinence and fecal incontinence. And average duration of this stage is about 3.5 months to about 9.5 months. And then they progress on to a severe dementia, where the speech is affected, they can't ambulate independently, they can't sit up without assistance, they can't smile, and finally, they can't even hold their head up. And that's how they progress. And the average duration at this stage is about 1 to 1.5 years. So you can see that when the condition progresses and then they reach towards the last stage, there are tendency for things like recurrent aspiration pneumonia, when the speech is affected, solo is affected, that's when they tend to become more unwell and have difficult hospital admissions. UTIs can be there. So this all happens because of the progression of the condition. Now, what all should we be doing as palliative care interventions in dementia? The first important thing that I told was about symptom control. So the main symptoms we discussed and what all symptoms they've got, we have got to manage accordingly. Along with that, we have a role in advanced care planning and avoidance of potentially burdensome treatments, hospice or palliative care referral if possible, as well as caregiver support. So if you use a fast scale, you can denote at which stage of the illness they are. And we all know that it's not a reversible condition, it's a progressive condition. So we should be able to explain to the family about this is because the disease is deteriorating, and it's better if we keep them at home and manage the symptoms rather than taking them to hospital to subject them to any burdensome treatment. So it's important for us to know at what stage of dementia there are, and it will help us to actually make these conversations with the family. So I'll introduce you to another patient now. Here's Mr. Krishnan, and he's in a local nursing home. He's 86 and he has got dementia. Now he's bedbound, he's doubly incontinent, and he manages a small amount of modified texture diet. The staff at the home comment that Mr. Krishnan hasn't been his usual self in the last week. He hasn't managed to eat or drink and has become very quiet. So it looks like he's in an advanced stage of dementia, and now he's not eating and drinking, and he's very quiet now. So how will you manage the patient? Again, please put A, B, C, and D. So A is write an outpatient referral to gastroenterology team for consideration of a percutaneous endoscopic gastroenterology. So PEC referral for him to improve his nutrition. Second, send a urine sample for culture, prescribe antibiotics for a possible urine infection and await results. Clinically assess Mr. Krishnan for any reversible cause of his dehydration, such as infection, pain, or constipation. If these are absent, ask the nursing home for details of Mr. Krishnan's relatives to discuss end-of-life care and refer to physiotherapy to see if they can improve his mobility. So what option will you do? Is it A, B, C, or D?
There are, most of them are C with 1 or 2 D.
So yeah, I think the best course of action probably for Mr. Krishnan would be to look for any reversible causes. So you don't have to typically do a urine infection. The most common thing that everybody thinks is probably he's got an UTI. And we know that all dementia patients, when they become more confused, people think of UTI and start treating them. But actually, it might not be the case. There's something called the behavioral and psychological symptoms of dementia patients, called BPSD, which can happen on and off for about 8 weeks time, and which probably might not even have any cause, and patients really become unwell and become very confused and agitated. So every time people think it's UTI and start treating them. So what we can do in this case is we know that he's in end-stage dementia, and he probably is towards end of life. You can clinically look for irreversible causes, and if you don't think it's infection clinically, if there's no pain or constipation, maybe it will be in the best interest of Mr. Krishnan for the nursing home people to get his relatives and discuss end-of-life care. At this point, there's no point in referring him for any artificial feeding because he's towards end of life, and again, we can't get his strength of the muscles back. So I don't think there's a rehab potential for him at this stage. And I don't think it's better to actually refer him to physiotherapy at this stage. So here's where, again, for this condition, we manage the symptoms as well as we involve in advanced care planning for such patients. Okay, which among the following is the most common symptom of advanced dementia? And the quiz at this time, is it confusion, urinary incontinence, pain, or low mood? I hope most of you got this correct. It's confusion, which was discussed earlier on. Okay. I'll quickly mention a few other neurological disorders. Again, the reason I mentioned them is they can have some typical symptoms which we manage with the drugs that we commonly use in palliative care. So things like amyotrophic lateral sclerosis or motor neuron disease, Parkinsonian syndromes, multiple sclerosis, ischemic or hemorrhagic stroke, or other conditions that sometimes get referral to palliative care. And again, depends on on where you work. So in where I work currently, the National Health Mission has, and the palliative care support services in Kerala and the government setting is very, very strong. So we tend to get a lot of non-cancer patients, especially stroke patients, paraplegic patients, bedridden patients, and we do a lot of home care services here. So, and I think rather than bringing patients to hospital or outpatients, we tend to go to their home and manage them. So that's why in the community, we get a lot of referrals like stroke and such patients. So, you might have to manage some symptoms that these patients can typically have. So things like constipation, so the management is similar to what you learn in constipation, but to make sure you start at the correct time, to make sure you check the bowel habits of the patients that you review. Things like dyspnea, you can manage with opioids. Any anxiety because of dyspnea, you can use benzodiazepines for that. Fatigue, sometimes you use psychostimulants and SSRIs to manage fatigue. Muscle cramps, again, common in neurological conditions. Quinidine is quite useful for that, for muscle cramps. Pain, you manage with WHO ladder, but sometimes you'll have to use neuropathic agents also, and antispasmodic agents. Some patients can have pseudobulbar effect, which mainly which cases affecting the nervous system. So basically, it can make you laugh and cry or become angry without being able to control when it happens. It's like an emotional dysregulation. So emotional incontinence, emotional ability. So people are involuntarily crying, and what they have suggested is that SSRI can be tried for that. Quinidine again can be used, or SSRI can be tried for that. Then there are things like hypersalivation in some patients. So we use amitriptyline or hyoscine for that. For psychosis, agitation, or irritability, quetiapine can be tried. Clozapine can be tried. If some sleep disorders are there, you try clonazepam and melatonin. And obviously in motor neuron disease patients, again, the advanced care planning becomes very important. So discussions about using non-invasive ventilation, using a tracheostomy for such patients, and if needed, a symptomatic treatment with morphine can also be tried. For Parkinson's in patients, so rigidity and bradykinesia are the symptoms. So you could try things like amantadine, or you've got new patches like rotigotine, and apomorphine can be given a subcut in infusion, as well as midazolam. Other things like for insomnia, we tried sopicolum and solpidem. Amitriptyline and mirtazapine is a newer antidepressant which can be tried for insomnia. Then some neurological conditions can have spasticity. So we refer them for physiotherapy. Then baclofen can be tried for antispasmodic measures, or tizanidine. Secretions can be both thick and thin. If they're thick secretions, we give mucolytics, and and supportive measures like nebulized saline can also be used for that. So these are some of the symptom management measures which might be useful and can be useful for such patients. And if you get involved. So we come to Mr. Ali. He's a 73-year-old. He has got advanced Parkinson's disease. His wife has brought him to see you because he has been vomiting. He has had little appetite over the last couple of weeks, and now he tends to vomit whenever he tries to take anything by mouth. So again, there are 1, 2, 3, 4 options, A, B, C, D. Which of the following would be an appropriate action to take? A, explain the vomiting has been caused by his medication and start Mr. Ali on appropriate antiemetic. B, explain that Mr. Ali is likely to be approaching end of life and needs to be admitted to a hospice. C, assess for any reversible cause vomiting and prescribe prochlorperazine, which have view to assessing him again in a few days to check for a response. Or D, assess for irreversible cause of vomiting and prescribe domperidone with a view to assessing again next few days, check for a response. Okay, so
you can see B, sometimes C also in between. Okay. C and D, mixed response.
C and D or B?
C and D, it's a mixed response.
Okay. So the question I asked was mainly to see whether what is the correct antiemetic you can give for Parkinson's patients. So we know that Parkinson's patients, we need to avoid a lot of antiemetics, including metoclopramide and haloperidol and prochlorperazine, because it causes extrapyramidal side effects. But domperidone doesn't cross the blood-brain barrier, and it's the safest one you can use. You can also use actually emisset or ondansetron can also be used, but other antiemetics will have to have, and cyclizine because of anticholinergic also is specifically best to avoid in Parkinson's disease. So it's best to go for domperidone, which doesn't cross the blood-brain barrier. And I don't think he's approaching end of life right now, so maybe we should treat his symptoms and then see how he gets on. Finally, we come to liver disease. So palliative care and end-stage liver disease. So what all can we do again in such patients? Again, end-stage liver disease, prognosis is very important. It's not easy to say when they're reaching end stage, so we'll have to have discussions with family about that. Symptom management, again, very important in liver disease patients. Lots of symptoms they can have, and so we have a role in that. Advanced care planning and end-of-life care. This is from this PIC tool, which I spoke earlier on. And what is at which point do we start palliative care for liver disease patients? So what they've told in the tool is that advanced cirrhosis with one or more complications in the past year, which includes it can be a diuretic resistant ascites, which requires recurrent drainage. Then patient has an episode of hepatic encephalopathy, hepatorenal syndrome, bacterial peritonitis, or recurrent variceal bleeds. If there is one or more complications in patients with advanced cirrhosis, and that is at the point that SPIT suggests that you have to get palliative care involved. Now, there are a number of ways to actually describe prognosis in liver patients. So what they say is that when the patient is actually have got compensated cirrhosis, so when they are in the early cirrhosis, when they don't have features of decompensation, they've got a median survival not decompensated, or if it's compensated, they can actually probably live for 6 to 12 years. But the minute they become decompensated, so things like having ascites, bacterial peritonitis, or hepatic encephalopathy, or even coagulopathy, all those are features of decompensation, then the prognosis comes down drastically. And the average year is only 2 years. Now, when the patient reaches ascites, what they say is that 50% of patients actually die within 2 years. So 2-year mortality is 50%. And if it's refractory ascites, the median survival comes down to 6 months. Now, if there's refractory encephalopathy, then the prognosis is only 1 year. And worst one is actually for the hepatorenal syndrome. Hepatorenal syndrome, again, can be 2 types. It can be type 1 and type 2. Type 1 is, comes on pretty quickly. It's abrupt deterioration of the renal function in less than 2 weeks. And what happens is that there's a doubling of the baseline creatinine to more than 2.5. And actually the prognosis is very, very short in such patients, only 4 weeks. Type 2 is a bit more gradual onset of renal failure. And the prognosis is supposed to be 6 months. So these are some of the criteria in liver disease patient, which will help us to decide on the prognosis, and again help us in our conversations with the family. So it's median survival for end-stage liver disease patients in months. As I mentioned, decompensated comes to about 25 months or 2 years. Once there is encephalopathy stage, it comes to 12 months or 1 year. Refractive ascites comes to 6 months, and then renal failure, it becomes a few weeks. So it's important for us to know all these factors. So coming to the barriers, why doesn't the physician, or why doesn't the patient get the adequate palliative care involvement? So the main problem is, I'm sure you must be familiar with this graph of disease trajectory, where cancer patients, it's a bit more predictable how they progress. So they'll be having treatment for some time, and then they have a sudden deterioration, and they come down, and they actually reach end of life, which probably is much more predictable than the second graph, which is the non-cancer conditions, where they can go on with some treatment for some time, and they'll have a dip and they become more unwell. You have conversation with the family about end of life care, and then actually they become better, go back to not to their baseline, but slightly lower than their baseline, go for some more time, then come down again, and then they go back up. So there can be dips in their trajectory. So it's not very easy to predict when a non-cancer patient reaches the end of life. And similarly for frailty and dementia also, they can dwindle down and reach end of life. So it's not easy to predict that. So why do these patients don't get palliative care involvement? There are some barriers discussed. Mainly the professional ones are not knowing how long the patient will live. So it creates an uncertainty. It paralyzes the doctors. So it potentially prevents them seeking palliative care. Even doctors have a natural desire to be optimistic, because the word palliative means that it's like it's like end of life care. So the doctors don't want to accept the fact that the patient is actually palliative care, and they want to avoid alarming the patients with the unnecessary thought of impending death. Now, the perception that death is a failure, if you think that you think that we are giving up on patients, you don't want to be thought to be like that. Sometimes we have lack of skills of symptom control, lack of specialist palliative care service and resources, and hospital policy. So all these can be the professional barriers in referring such patients for palliative care. Now, the patient and family also has got some barriers involved, because patient and family thinks, I don't have cancer, then why should I see a palliative care physician? And they also don't recognize the condition as terminal illness, and there's poor preparation in their part. And sometimes the caregivers are also a bit unprepared to decide the transition from a life-sustaining or aggressive treatment to a comfort care. So we come to a tool again. So all this, when you get a chance to go to the SPIT tool, it's very, very, very useful tool for us to decide when to refer, certain conditions. So in the case of heart failure, we discuss a New York Heart Association class. So it's class 3 and 4, or extensive untreatable coronary artery disease with symptoms of breathlessness, chest pain. If it's vascular disease or peripheral vascular disease, severe inoperable PVOD with gangrenous extremities, kidney disease, again stage 4 or 5 chronic disease with deteriorating health, and kidney failure which complicates the life-limiting conditions or treatment. Stopping dialysis, as I mentioned, once you stop dialysis, the average duration, average life expectancy only 9 days. So better to refer them for end-of-life care. And advanced diabetes unresponsive to treatment with deteriorating health, including a kidney failure. And liver disease, I've covered this already. So advanced cirrhosis with any of these complications, we have to refer them to palliative care. So access to palliative care should be based on the need rather than a diagnosis. So you can't be just the diagnosis. Coming back to a serious health-related suffering question, any patient who has got a health condition and is suffering because of the health condition should be referred to palliative care. It has to be based on the need of the patient, not of the diagnosis. There's another important tool or question that can be used to actually initiate this conversation, to initiate this referral. Would I be surprised if this patient died within the next 12 months? So suppose you're seeing a patient in your outpatient and you look at the patient and you think, will I be surprised if this patient died in the next 12 months? And if the answer to your question is no, that means you will not be surprised if the patient died in the next 12 months, then maybe you should think about referring the patient to palliative care. So that's a surprise question. So to conclude, palliative care is needed for patients with serious health-related suffering, which includes both cancer and non-cancer. And there is a need for further research into the needs assessment tool for specific conditions, as well as evidence of benefits of the palliative care mode. Thank you very much for listening.
Thank you, Dr. Sunitha. We can take up 1 or 2 questions before moving on to the presentation, patient story presentation. Is there any question that we can take up right now?
Excuse me, ma'am.
Yes, Dr. Shweta.
Ma'am, I want to know that presently, I am working in a critical care setup. I'm working as an intensivist, and I really see a lot of patients, for example, of a stroke or end-stage kidney disease. I would say they are rather being mismanaged in the ICUs, because we know that those are terminal patients. So how can we sensitize the hospital authorities or the relatives regarding the need for something else? Because palliative care, especially in northern India, is not so developed as maybe in parts of Kerala or the southern part of India.
Yeah, I think that's a very good question, Dr. Shweta, and it's very important also. And I'm glad that you as an intensivist actually is thinking in that terms. And I know that you don't have much support in other parts of the country, but there's a lot of work being done in India itself about palliative care and intensive care. And in fact, recently, the Karunashraya, I think they have started a new series on palliative care and intensive care. There were some lots of webinars on that. So the first one probably would be to have this conversation among your team members in intensive care itself, have a discussion. There are some guidelines which I can share with you. So about the intensive care management and things about withdrawing, life-sustaining treatments. There's a position statement developed by the Association of Indian Intensive Care that's quite old, and I think maybe 2018 or something. The position statement was there about which all conditions you can have a conversation, which all conditions you can withhold life-sustaining treatment. So I'll share that document with you. And things like, how do you do that in a private hospital? So, that in public hospital, always there'll be a shortage of beds and shortage of intensive care beds. So this medical ethics of justice comes into play. So people who need it more might be given that. But in private hospitals, might not be there. So we have to have conversations with the management. There are some techniques that people have been talking was about, if the management is worried about losing a patient's finances. So things like a patient who reaches end of life care, if they are in intensive care, they actually don't bring much money to the management because you don't do much investigations in such patients. You just keep them in the ICU to continue life, isn't it? So it's better to move them out of intensive care and move them to a ward, and that bed can be taken for other patients who probably would be bringing more money to the hospital. So that's one of the ways you can put it to a private hospital. I'm not saying that's the right way, but there are different ways where we have to approach the management because everybody won't think in the way as you as doctors think. We in Amrita, when I was working in Amrita Hospital, we tried the same thing, and we sort of talked to the anesthetists working in intensive care unit about things like withdrawing from the ventilator, because they also know that once a patient reaches into ventilator, they also feel there's no point in continuing, but they don't know how to initiate that conversation. So the conversation was initiated by the palliative care doctor, spoke to the family. I told them about how they're suffering, the fact that you're not able to see your loved one when they're at the end of life. So we, initiated conversations and sort of wean them off the ventilator, discharge them outside the ward so that the family can spend time with them. So all these need a lot of work, but actually you having a thought like that is probably the first step in the right direction. And I'm happy to share the document with you.
Thank you. Ma'am, excuse me. I just want to share a few things because the chronic diseases, whatever you were mentioning, I am seeing a lot of them. Like chronic kidney disease, huge load of diabetes in Northeast India. So one thing what I have noticed that providing palliative care for chronic diseases apart from cancer is a very difficult thing because the physician has to have diverse knowledge like CKD and the exacerbation in between and the COPD exacerbation, chronic breathless syndrome. The name you are treating cancer, pain in cancer patient, end stage is a bit different. And in non-cancer patient, you have to have diverse knowledge. So mastering those things and providing, you have to take diverse group of diseases under you. So definitely you have to be very confident so that you can give them adequate care. It's not that with only pain medicine they will be relieved. They have to, and patient and the relative, they expect a lot from the clinician. At least care also. The most of the chronic disease patient, they don't follow a particular pattern like that. Most of the patient I have seen, they are going, suddenly they died. Because one exacerbation, maybe with sudden infection, even simple LRTI, may precipitate the situation, worsen the situation, they will die. So things are not that predictable, but few percentage, they will definitely get some comfort from palliative care. But physician, the general physician, family physician, or the practitioner under whom the medical officer in a normal OPD, sometimes some intern is seeing, sometimes some medical officer who doesn't have adequate experience is seeing that patient, will not be able to take care of such type of patient. So their phase is a bit difficult, ma'am.
Yeah, I agree, Krishna Priya. So I think that's the reason we need a lot of sensitization. This is only a start. So I mentioned about studies in from UK, but at least the renal supportive care we have made a start in 2018. The ICU care we are starting to have discussions. All of our conferences and IOPCON conference is going to come in February next month. Again, we have got a slot on non-medical conditions. So everywhere when palliative care was first started for cancer patients only. And it's the same in Western countries also. Cancer patients still get more palliative care, and non-cancer don't get. So it all has to come from our undergraduate training onwards, and then it's basically sensitization. What we tend to do is we get lead clinicians. So in a specialty, there might be somebody who's interested in palliative care. So we make them champions of the specialty. We consider them as lead clinicians and sensitize them, invite them for training. So if there's a pulmonologist who has got a special interest in palliative care, you teach them about palliative care principles, then they'll be able to manage both. They'll be able to manage the pulmonology aspect as well as palliative care aspect. Similarly, cardiology, you get a cardiologist who's interested in palliative care, then that's it. So you don't have to learn. Basically, what we believe in Kerala is that we don't have to learn everything, but we empower the other specialists to incorporate the principles of palliative care into their specialty. That's the only way we can actually make it work.
Yeah. Yes. Thank you so much, ma'am.
Thank you. Are there any other questions, or should we move on to the case presentation and then?
Hi, ma'am.
Yes.
So what I have to ask is, usually in Kerala, what we see is the most of the advanced disease patients, they will be having their maintenance HD in 2 days difference, or like maintenance HD twice a week or thrice a week. So for them, their belief is that when I take the dialysis, I'm going to be okay. I have to take this dialysis to survive. So how to convince that patient who is dependent on the MHD to survive to stop, to think about stopping the HD, which he is very used to taking.
Yeah. So, what I meant was normally we don't actually, so we have to have this conversation before they start dialysis. Okay. The discussion about, so this is what dialysis involved, and dialysis means all these things are there. And this is what the conservative route involves, where you don't go into dialysis, but it'll be managed conservatively. And that conversation has to happen before they go into dialysis. Once they go into dialysis, then I don't think it's appropriate for us to initiate that conversation, because we know that they're definitely, if they depend on dialysis, when we stop the dialysis, that is going to be, and they're going to die pretty quickly. So then the conversation probably has to come from the patient side itself. So suppose they initiate the conversation saying that, okay, I'm fed up of my life, I can't progress on, then you have to support that decision. You'll have to tell them, okay, fine, you've got an option of not going in dialysis, and you speak to the family, and then you can say that whatever symptoms, whatever distress you have because of the decision, we'll manage that. So this is just like putting on a ventilator, isn't it? These are all life-sustaining treatments. So PEG feeding, non-invasive ventilation for MND patients, typical scenarios. So you know that they're going to progress and go into respiratory failure. So you have a conversation, you do an advanced care planning with them and say that we know that it's going to progress, you're going to go into a respiratory failure. Do you want to be connected to a ventilator? That means a non-invasive ventilator for the rest of your life, because that also becomes burdensome after some time. I've had patients in UK where actually I was involved in him going into an NIV because that was an emergency admission, and I had to send him to hospital. He came back with an NIV, and after 12 months, he came back to the hospital requesting to be taken off the NIV. And coincidentally, I was on call at that time, and I had to do the conversation of putting on him on sedation and actually withdrawing the NIV. So these are all very, very difficult situations. There is no right and wrong answer. It comes from experience. It's not black and white. You have to do it patient by patient, and you have to follow the cues of what the patient says. This particular patient I was talking about actually was fed up with the fact that he was connected to this machine all the time, and he decided he didn't want to live like that. But initially, when it first happened, he thought he wanted to live. So that is how patients will change their mind. We will change our mind. So you can't initiate a conversation unless patient probably gives you the cue to start the conversation. But our role is actually not to decide something and tell them this is what you should do. Is make sure the patient makes the decision, but to support them in whatever decision they take. We might not agree with the decision, but it doesn't matter. We have to support them in whatever they take.
Okay, one more question, ma'am. How does morphine help in dyspnea?
Okay, so you didn't have a breathlessness session yet, Sridevi?
Not yet. That is yet to come.
It'll be covered, right?
Yes, that is.
It'll be covered in that. So I've sent this in the chat. I've given a link for the document that Dr. Shweta. So if you can click on that, they'll give you the paper. It's a position statement. The same document I'm talking about how to withdraw in Indian intensive care. So it's a very useful one for us to follow.
Thank you. I think we'll move on to case presentation and then we'll come back to the discussion part. Okay. Dr. Samir.
Good evening. Am I audible, ma'am?
Yes, Dr. Samir.
Yes. Good evening. I am Dr. Samir, Associate Consultant Anesthesiology and Pain Medicine in Medanta Hospital, Ranchi. I am going to present case of 54-year-old male suffering from decompensated chronic liver disease. Presenting complaints are shortness of breath, abdominal distension, and disorientation. Patient was relatively asymptomatic before 2 years. Then he developed jaundice. After further investigation, he was diagnosed with cirrhosis of liver. Uh, Previously, 2 episodes of loss of consciousness, abdominal distension happened. First episode was 6 months back, and second episode was 2 months back. But patient recovered after hospitalization and treatment provided there. Liver transplant was advised at that time, but patient cannot afford due to financial reasons. Now presented with above mentioned complaints. Oral mucosal bleeding started during ongoing treatment. No history of diabetes, hypertension, or hypothyroidism. Known case of alcoholic since 20 years. Has stopped since 1 year. Means after diagnosing with this condition, still he had taken alcohol. On examination, pulse was 102 per minute. BP was 98 by 70 mmHg. SpO2 was 96% on room air. Respiratory rate was 24 per minute. Abdomen was distended and fluid thrill was present. CNS patient was disoriented with GCS of E3, M5, V3. Respiratory and CVS are normal. Important investigations. Hemoglobin was on lower side, 9.4. TLC was 8,900. Bilirubin was increased, 3.29. Urea and creatinine was normal. Albumin was on lower side, 2.25. Ammonia was on higher side, 497. And sodium was also on lower side. PTINR deranged. Respiratory alkalosis was present in ABG. Treatment and significant investigations. We have done USG guided ascitic tapping. Over 6 liters of fluid came during tapping over 3 days. Lactihep syrup and lactulose retention and enema was given to improve neurological condition. We have started parental nutrition because RT feeding was not possible. Large amount of RT aspirate was coming. Antibiotic, antiemetic, prokinetic, and other supporting medications. Psychosocial aspects. Patient is an atheist by religion, Hindu patient, working as lab assistant in a prominent IIT. Chronic alcoholic, so not well accepted in relatives and neighborhood. Only earning person in the family. He has a 22-year-old adopted daughter, unmarried. She is the only child, no other. Medications provided was these: pan 40, ondem, perinom, antibiotics, vitamin K, udiliv, and other supportive medications. Main concerns was nutrition, symptomatic improvement, unacceptability among relatives for progressive nature of disease. They were not accepting that his condition is not going to improve and patient is not going to live long. Summary. A 54-year-old male, known case of chronic liver disease, presented with shortness of breath, abdominal distension, and mental disorientation. Discussion points are when to start palliative care, how to convince patient and relatives for need of palliative care and advanced care plan, uh, home care or hospital care for him, how to provide better symptomatic treatment.
Thank you, Dr. Samir. I think in Dr. Sunitha's presentation also we have heard about managing the end stage liver disease towards end. So I would like to hear from other participants, what do they think, when to start offering palliative care, or when should we start the conversation with the patient and the relatives? Based on today's session, what do you think will be appropriate in this kind of situation? Anyone can answer or comment.
Ma'am.
Yes, Dr. Shweta.
Ma'am, I think this is the right time when we can start counseling the relatives towards the need for palliative care. Like once we know that the patient is developing ascites, he has episodes of unconsciousness, then a massive amount of RT aspiration is being done. He is already heading towards the end of life. So this issue should be better discussed at this point with the family members, so that at least they are aware that this is not going to last very long, and they get mentally prepared and also financially.
Thank you, Dr. Shweta. Any other comments? I can see Dr. Shivkumar commented that a patient can be counseled for palliative care now. So Dr. Shirley is mentioning that we need to explain the prognosis at the time of diagnosis itself to inform the patient of the probable symptoms to watch out for. What do others think about it? So she's suggesting that we should start talking about the prognosis at the time of diagnosis so that they can be prepared for the symptoms and what are symptoms they're going to deal with. Any comments on that? Any thoughts?
I think we actually had to start discussing about the palliative care from the not at this part. We have to start before itself because once he's admitted, and it will be more close to end of life care. We actually had to start a discussion somewhere in the past when he was having this repeated ascites tapping being done. And also, I think more problem with liver patients is that there is a hope of the more discussion from the medical side goes around the chance of having a transplant. That is the focus of, I think the gastroenterology is aiming to that, giving that these problems will be cured only with a liver transplant. So you have to get the transplant. Because for me personally, this happened to my uncle, who actually was refused to get the transplant because he had a pneumonia also, but he got the transplant done. But he didn't survive. The family also suffered a lot financially and emotionally after spending about 2 months close to the ICU, and they had to go through a lot, which could have been avoided. So I think this conversation had to start somewhere in the past, where the patient and the relatives are very they are told that this is not going to get better, or so we have to think about other management about making him comfort. So that is one thing. And about
yes, please continue.
And symptomatic treatment, I think we still can give symptom based. We can, I think, tapping. I don't know. It's a little. I'm confused whether we have to proceed with the tapping to relieve his symptom, but I think we have to do that. But otherwise, then we can if he's going into hypertension, or if he is getting other kinds of TPN, we can avoid. I think, but definitely we can avoid TPN. and we can reduce the amount of intervention from our side. Thank you.
Thank you, Dr. Sanjana, for sharing your thoughts and your personal experience through the illness. So, Dr. Sunitha, that might be the usual question that you hear from this kind of sessions, that when to start this conversation, whether it should be at this point where this patient is going through, or it should be at the time of diagnosis, or as Dr. Sanjana said, somewhere in between, not now, but somewhere in the past. So when do you recommend to have this conversation?
Yeah, I think, so ideally probably at diagnosis, but not at the first consultation. So usually such conversations, in my personal opinion, is you can't do it in the first consultation. You'll have to have a rapport, establish a rapport with the patient and family. But in this case, this particular patient, he was diagnosed around 2 years back. He was asymptomatic, then 2 years back he was diagnosed. And then, then subsequently he developed all these compensation features. So, and he was drinking till 1 year back. So maybe he wouldn't be a candidate for transplant even if they offered that, but financially he couldn't take that. Now actually, if you look at the investigations, his bilirubin is high, his albumin is low, his urea is quite high, his PTINR is abnormal, and he's got ascites, and that's about 6 liters over 3 days. And he probably has hepatic encephalopathy also. So if you look at the prognosis that I was mentioning, if you look at the SPIC tool, he's got all the criteria to refer to palliative care at this point. And even the prognosis wise also, his renal failure probably is pre-renal, but he probably can go into renal failure soon. So that is one of the reasons why we need to get this conversation started, because we need to tell the family, even if you involve palliative care or not, that is not the question. We need to first tell them how long he's got, isn't it? So it depends on all these findings. He probably doesn't have, probably has about 1 year. If it's refractive ascites prognosis, only 1 year. So that is the first message that they need to understand, because these patients, they come to hospital, they get better, they go back, they come again, they get better, go back. So the family doesn't know that one of those points, that might be the last one. So they need to know that. I think there is no, it's better to, he should have been started before this admission, but if it's never been done before, then this is the right time to start. The earlier, the better, especially for such patients. Again, if you are able to set up a service where you can provide ascitic tapping at home, well and good, then that's the only reason the patient sometimes needs to come into hospital. It's been done. We can do it at home. We do it here. So these are things that you as people who are interested in palliative care should be thinking about, things we can provide at home for this patient. So this up to 5 liters you can actually drain at home without any albumin cover. So we do that in our setting here. So that's something that you can think of that can avoid this hospital admission also.
Thank you, Dr. Sunitha, for your inputs. Is there any question that you want to ask related to that she was mentioning about when to start the conversation, optimizing the treatment, how to take care of these issues at home, touching upon a little bit on nutrition, how to provide symptomatic treatment? Any comments on that, or any questions?
Other point I want to mention was that TPN was started for him. So again, what are your thoughts on that? As a team, what do you think that was appropriate to start TPN on him or not?
Ma'am.
Yes, Dr. Shweta, please.
Ma'am, I think we should not hold nutrition as long as there is life. Like by whatever means we can feed the patient, as long as there is tolerance, we should try to think and proceed in that direction. It could be either TPN, or sometimes surgically we create passages so that we can feed the patient. In the earlier stages, it may be nasogastric feeding. But in my opinion, I think feeding should continue as long as life exists.
Okay, anybody else has got any other opinion?
But there is a chat that whether TPN worsened his hepatic encephalopathy in this patient is by Dr. Shivkumar. Anyone else would want to comment on the TPN?
Ma'am, that is surely a known side effect of TPN, but that has to be assessed by other parameters as well.
Continue feeding is other by TPN is another comment by Dr. Sunil. Anyone else do not want to give TPN? I mean, any comments? I just wanted to know what others think of it.
So suppose this patient says family says they can't afford any further treatment and they would like to take him home. So how are you going to continue TPN at home? I'm just putting a question out.
Of course, ma'am, we cannot do TPN at home, but then we will suggest some remedies by which he can be fed at home.
Like?
Whatever he can take orally, or if they agree for some surgical methods, like we do gastrostomy or gastroduodenostomy, those procedures, if they agree, we can do those procedures for them.
Okay. There is another comment by Dr. Shaurya. TPN is a lot of fluid. Decompensated patients can land in severe fluid overload if not monitored properly. And he should continue the hospital care with TPN and tapping for symptoms.
I like this comment by Sanjana. So I think treatment in our country is totally based on the family can afford it and how long they can afford it. And I think that is true, Sanjana, but it shouldn't be, isn't it? Because this patient probably, you're right, because if you look at his prognosis-wise, his renal function is not too bad. He might not die imminently, and this might not be his end of life. So if it's for short-term TPN for that reason, okay, that's fine. But there are patients, like especially cancer patients, I know, who can't take anything by mouth and who are clearly reaching end of life. But people insist on feeding them. And this is a very, very sensitive issue. And patients also, especially the family members, become very, very traumatized or upset if you say that, you can't feed them. And if we say it's not appropriate to put rice tube or NG feeding at the end stage, because we all believe that they have to be fed till the end. And I hope there is a medical ethics session, Sridevi, and I hope this will be covered.
But I think we already had that.
So feeding issues was not covered in that then?
Not really, but that will be coming in end of life care. Probably.
End of life care, yeah. Because this is a common discussion we have to have with patients at end of life. There are a few data, few research done in patients who are actively dying, especially the blood parameters were taken in such patients. And what they found is that there was no signs of dehydration and people were not dehydrated at that stage. We compare cancer to like a parasite in our body. So whatever we feed the patient, it's going to go to the parasite. So the patient is not getting them. And what happens towards end of life is the body tends to shut down. The need for food comes down. Unless the patient says he's hungry, if it doesn't say he doesn't need anything, then what we normally advise is not to force feed them. Situation like this, when you say, okay, you can give TPN at hospital, etc., but the patient has got financial problem, they're going home, you can't do it at home, then the bystanders feel that, okay, just because I don't have money, I can't feed my bystander because I didn't have money to give the TPN in hospital. So these are some dilemmas which we shouldn't be putting the family through. We should be making a medical decision, right? Does this patient need feeding or not? Does this patient at this stage, if we feed them, is it going to help him or not? As opposed to a patient can be fed because he's financially okay to have a TPN. So all these things you have to think carefully before we make a decision in that. What we say towards end of life is definitely let him eat and drink as much as he wants by mouth. So if he says he needs something, you give it to him. Whatever he asks or he or she asks for, you give it to them. Just because diabetic, don't give sugar, no, nothing like that towards end of life. But whatever little they want, let them eat through their mouth. Don't force feed them, and don't sort of keep it away from thinking that they're going to be had problems of choking and things like that. If they're aware enough to take something by mouth, they can have it. So this is very, it's not an easy scenario. Yeah, go on.
Ma'am, I read somewhere, I am just confirming this thing from you, that it's not that before death, end of life, somebody suffering from severe pain cannot take anything. Gradually they go to, if they fast, they cannot eat anything, they go to a stage of ketonemia. And that ketonemia produces analgesia and euphoria. It is not that painful. Is it right, ma'am?
I've not read about that, Krishna Priya. I can check and get back, but I've not read about that. So
I cannot just
definitely pain has to be
tell you
controlled.
the book, but I read from some site in net, authentic site, I think medical site. But I just wanted to cross check it.
So because they're starving, they go into ketonemia, and that just doesn't cause some
and
pain.
ketonemia gives analgesia and causes euphoria. So they will not become that painful.
Oh, okay, right. But what we teach is that, and what we like limited evidence is only that people don't tend to be hungry towards, and this is all for cancer patients, okay? Because whatever research has been done, end of life is only for cancer patients, not for non-cancer. Non-cancer has to be treated separately itself. So yeah.
And it becomes more of a cultural and emotional issue than that of a medical when it comes to the nutrition and feeding.
Nutrition, yeah.
So there is a long message. I'll try to read.
Okay.
Yeah, that's a very good comment.
Yeah, Sanjana, I think that's the best way to go forward also. Because sometimes we end up putting subcut fluids for them at home. And what happens is that after a couple of days, the edema worsens, secretions worsens, and the family themselves say, okay, the edema is bursting, we'll stop the fluid. So we explain that to them initially, but still they won't agree. And then we end up going what the family wants. But if they're able to take it by mouth, that's the best thing to do. And whatever small amount they're taking, I would say, give some small amount of fluid, sips by mouth, or just wet their tongue. That's more than enough.
This is exactly the way we go about it here also, Dr. Sanjana. We talk to them about the lesser need of the body. And if they still insist a lot, we keep reminding them almost every day. And usually after a few days of hydration or any artificial nutrition, they themselves start seeing patients struggling with fluid overload. Then sometimes they realize and tell, okay, now we understand that he needs not be fed through artificial nutrition and hydration. Thank you so much for sharing that. Any other questions or comments before we close today's session? So thank you everyone for that wonderful discussion, because we also learn from when you ask these questions, we also tend to go and read and then. So thank you so much for this interaction, and thank you so much for joining us. Thank you, Dr. Sunitha, for the wonderful session as always, and for agreeing to be part of this program. Thank you.
Thank you all. I'll just share a link I'll send that to Sridevi for feedback for my session. If you could all, it's a Google form. So if you could give me feedback, that'll be great. Thank you.
Dr. Indu, you had a question. Sorry, you have raised your hand. I'm so sorry.
Ma'am, I'm sorry to be so late.
No problem.
I have a doubt, ma'am. We had a patient who had CVA 3 months ago, large MC tertiary infarct, and patient was on RT-feed since 3 months. But now the patient presented with scar seizures, and patient had and aspiration pneumonia. How do we communicate with the patient's bystanders regarding this kind of care, palliative care as such, ma'am?
Sorry, the patient presented with aspiration pneumonia?
Ma'am, patient presented with aspiration scar epilepsy. She had recurrent epilepsy seizure episodes, ma'am.
Okay.
She's presently admitted in ICU. So the patient is still she's also having aspiration pneumonia. She was intubated after refractory seizures. So after that,
do you expect her to recover from this aspiration pneumonia episode? Is she likely to be?
We extubated her. Even though she was still having infection, we extubated her when she was about to respond well, and she's about to spontaneously maintain do respirations. So after that, patient is still going on. She is not able to swallow, or she's not able to cough out the secretions properly. So she's always in a state of aspiration. That is what we feel.
So how old is this patient?
This patient is 65 years old now.
Any other comorbidities?
No, ma'am. She presented with CVA 3 months ago, and that time she was detected with hypertension. That's all.
So she had CVA 3 months ago. Did she recover from that CVA?
No, ma'am. She is completely paralyzed, hemiparesis, almost hemiparesis.
So what about feeding at the? Was she on a Ryle's tube feeding?
She was on Ryle's tube feeding.
And that's still going
since
on.
3 months. And that's still going on now.
But in spite of Ryle's tube, she's aspirating in between.
Yes, ma'am. All the secretions that is there in the oropharynx and whatever is remaining in the hypopharynx, that she is supposed to be aspirating anyway.
So that means she's not able to solo. Her GCS is poor.
She's not. She's responding to our commands, obeying to whatever we say. But sometimes she is a bit angry. She is resistant to whatever we tell. She may not swallow. She is not spontaneous swallowing is very less.
So again, so it depends on how much you expect her to recover. So if you don't think that her primary neurological condition is not going to recover, she's got a feeding tube there. So that part we have taken care of. You can feed her. But the thing is, even when the feeding tube is there, there's a chance of silent aspiration, which has happened for her case, isn't it? So you explain the risk to her, risk to the family, risk and benefit, and the fact that she can have recurrent pneumonia, and every time she ends up having a pneumonia, it's likely to end up in a ventilator if you don't do an advanced care planning for her. And one of those episodes, we might not be able to, she might have a cardiac arrest and we might not be able to bring her back from that. So what you could tell the family is that it might be in the best interest if she's not going to recover that. Next time she has an aspiration pneumonia, we keep her comfortable in a ward and manage a pneumonia, but we wouldn't do aggressive procedures like intubation or ventilation. So that has to be a step. So there are two ways to do this. One is you can have you should have a discussion about do not resuscitation. So do not resuscitation basically means that even if she is intubated and ventilated, suppose the heart stops, we won't start the CPR to resuscitate her. That has to be the first step. So you could decide on the ceiling of care. You can decide that, okay, this admission, ventilation was a ceiling of care. If she recovers from that, that's fine. But if she ends up having a cardiac arrest also, we're not going to start CPR to actually do the patient. We'll let her go in dignity. That is the first step. Next step, so you've recovered and you have brought her back, but she hasn't come back to her baseline, isn't it? She's still aspirating and it's chance that she's going to happen again. You can't do anything to prevent that from happening. You've done the maximum you could do. The other option would be doing a tracheostomy for her to do a frequent suction. If that's the one that is causing, I don't know whether that should be the right thing to do. But other than that, what do you do about secretions? Nothing. So you can't prevent that. So that's going to end up going to have another aspiration pneumonia. Every time she gets an aspiration pneumonia, by the time you intubate her, she's going to have a more hypoxic brain damage. This is going to be a vicious cycle. You can't bring her back. So it'll be better and kinder to her not to go into this route next time. For that, you have to have the second discussion about what is ceiling of care for the next time. You talk to the family, if this happens again, why don't we keep her comfortable in a ward rather than intubating her and transferring to the ICU, and see what they think about that. And she might recover, we don't know, because you can give, so you decide on the ceiling of care. So you can decide, okay, I'll give IV antibiotics for her, but I won't intubate her. Then she might recover. And next point, if they want to keep her at home, then you decide on oral antibiotics for her. You won't bring her to hospital, but you give oral antibiotics to the Ryle's tube and see how she recovers. All these things can be done. You don't know, she might recover, we don't know about that. So all these are levels of care, the ceiling of care. So the maximum is intubation, then to go down to IV antibiotics, but nothing more than that. Next to go down to oral antibiotics and keep her at home. And they might even agree to that also.
Thank you, ma'am. Thank you.
Okay. Oh, Sridevi?
Yeah, thank you so much, everyone.
All
So
right.
thank you so much for that response.
Thank you. Bye.
Thank you, everyone. Thank you, Dr. Sunitha, for your valuable time. I believe today's discussion was especially more interactive and informative to everyone out there. So, along with that note, this is Sripriya, along with Dr. Sridevi Warrior and Dr. Sunitha Daniel, signing off from the TIPS Echo Desk. See you in the next session with another interesting topic and an eminent faculty. Till then, everyone, take care. See you. Bye-bye.
Thank you. Bye.